Hey everybody, welcome back to my channel. Today we're going to be talking about colonic angiodysplasias. This is a pretty simple, straightforward um, segment. There's not much to do in here. It's a pretty simple pathology, right? So how do colonic angiodysplasias even come to be, right? First of all, the main pathology that you guys need to remember is this is more of a local thing. It's poor oxygenation locally, right? It's seen as dilated submucosal veins, and it happens because of colonic lumen distension and stress, and these are thin walled and they rupture easily. Most often colonic angiodysplasias, they happen in the descending in the sigmoid colon, right? So it is an important cause for lower GI bleed. Now how does it present? It presents with hematoschezia, sometimes sometimes melena, occult bleeding, and deficiency anemia, which I think is pretty obvious because you keep having occult bleeding, you're obviously going to become anemic with iron deficiency anemia. So the pathogenesis of we've already spoken about the pathogenesis, which is like local poor oxygenation, which causes the vessels there to be fragile. But there are these three clinical associations of colonic angiodysplasias that the boards will test you on. You want to be talking about end-stage renal disease, aortic stenosis, and LVAD stands for left ventricular access devices. Now, what I like to think of these three as, acquired von-Willebrand factor disease, right? Now, what happens in ESRD is that there is going to be excretion of ADAM TS13. This is the protein that you learned about during TTP, which is thrombocytopenic purpura. ADAM TS13 is responsible for cleaving, von-Willebrand factor multimers. Now, what happens when there's no ADAM TS13? It's that von-Willebrand factor multimers will form and it will get consumed, right? So when you want to think about the colon, and let's say there's angiodysplasia over here, let's say ADAM TS13 is gone and von-Willebrand factor got turned into multimers and got consumed elsewhere. It's not present at this point, at this place, when the bleed occurs to form a platelet plug and stop the bleed, right? So when that happens, the patient bleeds. It's a lower GI bleed. Now, when it comes to aortic stenosis and left ventricular access devices, these two, they pretty much have the similar pathogenesis. It's that aortic stenosis, left ventricular access devices, you know that that's going to cause a mechanical problem locally, right? And that actually causes damage to von-Willebrand factor multimers. So that's the so obviously you want to be thinking about von-Willebrand's disease itself, because that's like a congenital deficiency of von-Willebrand's factor, and then there's these three which are the acquired causes of von-Willebrand's disease. Now, how do you diagnose angiodysplasias? The first two are pretty simple. It's colonoscopy, failing which you might have to do capsule endoscopy. Colonoscopies fail when the angiodysplasias are like hidden behind the hostile folds or something like that, and that's when capsule endoscopy comes into play. And when both of these are not able to, like, when we think about imaging, when both of these are not able to yield a diagnosis, that's when we go in for more advanced modalities like selective mesenteric angiography, right? Now, obviously, the more basic stuff is Guaiac-positive stool and microcytic hypochromic anemia, which, these come under routine tests, but yeah, you'll be able to see that in colonic angiodysplasias. Now, the good thing about it is that 90% of the cases self-resolve with, the bleeding stops with just supportive and conservative care. You want to transfuse blood if the patient has lost a lot of blood. And for refractory cases, you want to be doing endoscopic obliteration using, electrocoagulation and laser photocoagulation, and also you can selectively embolize the arterial vessel, which supplies blood to this area wherever the angiodysplasia uh, uh, has birthed, right? And then you cut off the blood supply, and then you would cut off the bleeding as well. So this was a pretty simple topic. I hope you guys learned something. I hope this was helpful. Thank you so much for listening, and have a good day. Thanks. See you. Bye bye.